Okay, perfect. So
I'm
how's
going
the
to hit
flow?
share screen again.
Wait, Dr. Buddy.
Okay, okay.
Yeah, we do the introduction part and then you share the screen.
No, perfect. Whatever you guys say.
Yeah.
Yes,
Yeah,
sir. Yes, sir, we are live.
Okay, and hi guys, welcome again to our master class of Indian Arthroscopy Society. And this is a very, very special class. We have an overseas guest and a friend of India, Dr. Felix, popularly called as Buddy. And he has been coming to India for so many years and has been helping us learn arthroscopy and has been teaching arthroscopy in our country. I remember, I think 2006, I met him when he came, I think 5 or 6, yeah, 6. It was Calcutta. And Debashish and Samanta Dada and Kanchan invited Buddy to be in India, and that was a wonderful meeting. And he does remember, I believe. So, yeah, Buddy. Welcome to this meeting, and we really look forward to your inputs for this meeting. Samantha, if I can just pass on to you, and you can just introduce Buddy, and then we can go forward.
Yes, Buddy, I requested you for just to have this masterclass. I am really honored as the Secretary of the Indian Arthroscopy Society that you have taken our invitation. Thanks a lot. So go ahead with your presentation. Thank you.
Okay. Thank you very much. Let's see. We'll try to share screen and see if this will work. And
yeah, it's okay.
It's okay?
Yeah, it has made it the full screen.
Okay,
Sandeep, you
perfect.
can mute everybody else except Buddy.
So it's a great honor to be here on video. I'm sorry I'm not visiting your beautiful country. It's always been an honor to be involved with the Indian Arthroscopy Association. You guys are very progressive, and you're extremely kind to say that I was teaching, because I think we learn from each other, and you guys are terrific. So it's much fun to do this. So conflicts, I do get some royalties, and as you may or may not know, I'm now in the presidential line for the Academy. So I'm second vice president of the Academy, so it kind of eliminates all other conflicts. So again, it's an honor to be a part of this. So tips to improve the massive rotator cuff tear surgery. So, you know, this is an area been an interest of mine for a very long time, and it's always fun to share things we've learned, and I get a little bit better every year. So some parts of the talk are the same over the last 10 years. Many parts are different, and so we're trying to share new things and new techniques. So the 5 key points we'd like to cover during this session: 1, your preoperative evaluation; 2, how to do releases in surgery. And I'm going to spend a little bit of time on this because as I travel around the world prior to the pandemic, this seems to be one of the areas that many people have problems with, is what to release and when. And then 3rd, balance of biology and biomechanics. We've had a lot of industry sponsored techniques that, while very good, maybe lost the part of biology. Some extras that you can add in that have come around, and then a little bit of a talk about rehabilitation and nutrition, because I think that makes a difference. All right, so preoperative evaluation. You want to check your motion, and if it's stiff, think about releases. And the most common motion that's lost preoperatively is internal rotation. And so we want to make sure that the patient has internal rotation. If not, you need to think about releasing the posterior band of the inferior glenohumeral ligament to begin the surgery. A head that's superiorly migrated has to be brought down. The shoulder has to be flexible either by preoperative therapy or do it in surgery by doing your releases so that you restore that flexibility to the tendons. So look for passive range of motion, look for atrophy. An x-ray like you see on the top right where they have this arthritis, this is going to be stiff because of arthritis, and clearly trying to repair a rotator cuff in this situation is not a good idea. On the bottom one, this is a failed cuff. It's very interesting. It's a type 2 failure. So you see some tendon still attached, the anchors with a little bit of edema, a large gap, a huge acromial spur. So if you look at this, there's no way for that rotator cuff to have healed. The head is up. You have a spur here on the acromion. You have inflammation in the AC joint. And then if you look medially, you see pressure and adhesions around the suprascapular nerve. So if this case, just based on this MRI scan of this patient, you'd be thinking, well, I have a lot to do, because if I don't decompress the nerve, if I don't release that tight capsule, if I don't take the bone spurs away, the chance of healing is very, very low. So you can set yourself up to succeed or fail based on your preoperative evaluation. Positioning doesn't make any difference. If you like beach chair for rotator cuffs, it's not a problem. This is not like instability. If you like lateral, not a problem. Whatever your OR likes to do. So they're equal for rotator cuff repair. But you need to be able to pull traction on the arm. You need to have rotation of the arm. So your traction or setup has to allow the arm to move back and forth. So some of the arm positioners don't allow that rotation or traction. So you really need to make sure that that occurs. And then make sure you have good medial access. I train residents and fellows. And so one of the things that happens is that you don't have enough access way over here medially in the back and in the front to allow access to your retrievers and to get your sutures in good position. So you need to make sure as you drape, you don't drape out the field in such a way that you can't access the shoulder. Intraoperative tips: evaluate, 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 and continuously assess. Here's a posterior view, bursal view. You see the biceps with the tearing. We're now thinking, do we need to save that? We want to clean up the rotator cuff. We want to see where it wants to go. Now, we'll have already done our intra-articular releases, and we'll talk about that. But the key with massive cuffs is release, release, release. I think this is one of the things that Dr. Neer used to do open, and that we sort of lost with arthroscopy and speed bridge. But look how nice after this is released, that big cuff tear, which was to the glenoid, now comes right over the top. And this is where you assess your pattern of tearing. You want to know what's going on, and you need to be able to put it wherever it needs to go. So biology and releases are important. So what do we mean by releases? Well, if the inferior capsule is tight, we want to release that. I favor a hook because I'm very precise with what we do. But if you're a little rough or your hands move a little bit, there's no harm in doing a side effect. This inferior capsule, I think on almost every rotator cuff should be released. Unless you sit there and it's totally flexible and the head sits down on the glenoid, you really want to release this. It does a lot of good things. And as we come up, you can see the redness on the posterior capsule that shows you that this is an irritated shoulder. So the larger the tear, the more releases you want to do. And in a case like this, massive tears, we want to release everything. Look how tight this is on top. Look at the issues here. We need to make sure we bring that down. So when you're looking at the beginning, here's the biceps. We want to come in, and again, I like a little hook cautery. You can see the adhesions here between the labrum and the rotator cuff. These have to be released. There's no chance of us pulling that supraspinatus without tension back where it needs to go. You can argue about releasing or saving the biceps. The bigger the cuff, the more I try to save it and use it as a graft in one way or another. You can see there's a little arthritis on this head, and we have a concomitant small subscapularis tear. So we're going to release the anterior capsule. As we move to the picture to your right, you can see again these adhesions and how strong they are. You can imagine that that rotator cuff is not going to move. Now you want to make sure you get your plane correctly when you do this and not go into the muscle of the supraspinatus or infraspinatus. But here's our release. We're going to connect this back to our inferior release at the bottom. You can see the tendon, then there's just a gap of tissue and then a little bit more tendon. So all of this has to be put back together. So when we say we're doing releases, we're also continuously assessing what do we have to work with, what kind of problems the patient has in there that cause this. Let's see, there we go. The coracohumeral ligament needs to be released, and it needs to be released extra-articularly. Dr. Neer released that on every rotator cuff he did. I've been told that Dr. Codman released it way back, but I don't have any direct knowledge of that. It's not in his book, I know that. As we come down, we're looking from lateral. The CA ligament is to the left. And as we clean off that space, if we pull back on the shoulder a little bit, because we've done our posterior releases, we can find the conjoint tendon. And then as we move medially, we see a very large coracohumeral ligament. And that suspends the shoulder upward. So you can't bring that shoulder down unless you release that coracohumeral ligament. And here we are releasing it with a cautery off the base of the coracoid. You cannot do a complete coracohumeral ligament release from inside the shoulder. You have to come outside, and there's a band that goes to the subscapularis. a second band that goes to the supraspinatus, and then in tears, there's often many adhesions as you move medially into an anterior interval slide. So look at these adhesions, this band on this rotator cuff. And you might imagine that tethering is not going to come loose on its own. You have to go ahead and cut that in order to be able to treat a massive rotator cuff. Now, when you cut it and you combine that with the releases we've done inside, and in a revision case, the releases we've done off the bone, preserving it, but here's the base of the coracoid, maybe a tiny coracoid spur, nothing major. A conjoint tendon would be down and to the left. You can see we have a good release there that lets us see. So what does this do when we have this kind of release? Well, here's our humeral head. There's our rotator cuff. It's already been released, so it's coming over nicely. Here you see that coracoid base. We move medially, and if we pull traction, that head's going to move down and the rotator cuff will come right back over the top. So a 3 centimeter tear becomes a chip shot, very easy to fix with no tension on your rotator cuff. Whoops, let's see. Here we go. Okay, what about the bursa? So we want to spend a little bit of time talking about this. Udhoff has shown us that the lateral and subdeltoid bursa have MMP3 inflammatory cytokines. We're all in on the cytokine storm because of the COVID-19, but cytokines in the shoulder are bad. Feely has shown us that the blood supply to the bursa is the medial, to the rotator cuff is the medial bursa. We need to try to save that medial bursa. And Mazaka has some very elegant work that shows that healing cells come from the bursa. So given the limits that you still have to visualize what's going on, you really want to avoid the cautery around the bursa as much as you possibly can. Now, clearly you have to see. So if it's bleeding, you need to cauterize it, but the sort of the way some people do by putting that cautery in and just kind of ablating everything is probably a bad idea. In the tuberosity, you need to create vascular channels. 1 to 2 millimeter holes are probably the best. This is Steve Snyder's Crimson Duvet. We do these trephination holes across the tuberosity, mostly right off the articular surface, and then a middle row between where we want to put our anchors in. The next part would be vented anchors. The technology now allows us to use vented anchors, and I think whichever company you use should provide vented anchors. A lot of companies have all suture anchors for the greater tuberosity. I'm not sure they hold well enough to tolerate the stress of a rotator cuff, but if you do like to use all suture anchors, then your trephination holes should be a little bit adjacent to those so that you still get this healing. We did an ultrasound study on vented versus non-vented anchors and also compared that to a trephination hole. A vented anchor and a trephination hole on the medial tuberosity at 6 weeks had 1 millimeter on average thicker rotator cuff as compared to a non-vented anchor. So really makes a difference at that critical time of healing. Anchor and suture configuration. You need to have solid, stable fixation in multiple planes. You have to leave vascular channels. I'm not sure if you can see my pointer, but you can see the sutures, and between those sutures, we don't cross the stitches. We need this medial blood supply to come from the bursa laterally to the tuberosity. So we, rather than doing crossing stitches per se, we try to do different channels so that a mattress stitch, but then we leave intact tendon without any suture crossing it, and then a second mattress stitch, and then intact tendon coming around. We try to minimize anchors. Tendon does not heal to anchors, and even vented anchors will still have some problems. And so the less anchors, the better, but you have to balance that with the biomechanics. So every anchor we use in the rotator cuff is going to be triple loaded, sometimes 2, sometimes 3 medial. If we can get by with just 1, that'd be great. The same thing with lateral anchors. And so a good rule of thumb when you're thinking about anchors is the supraspinatus and upper infraspinatus has its own anchor. If you have subscapularis, it needs an anchor. If you have lower infraspinatus, it needs an anchor. And so as you look at rotator cuffs, it depends on the quality of the tendon, because the upper and lower infraspinatus actually act like 2 different tendons. The lower one comes around and does external rotation at lower levels. The upper one actually blends with the supraspinatus, and in radiologists, you'll see MRI reports calling this a conjoined tendon of the rotator cuff. And what they're talking about is the infra and supra blend on top. The lower infra, as Sugaya has shown us, wraps around. So they have different functions, even though it's one muscle. So the upper and lower are different and require different anchors. And then your suture configuration, the more crisscrossing you do, while still preserving those vascular channels, very important. I'd like to talk a little bit about margin convergence. We talked about this many years ago. It is Steve Burkhart talked about it back. Both of us discussed this in the late 80s and early 90s about how important it was. It's not really indigenous to either of us. This is McLaughlin's old baseball stitch. So this dates back to the 50s, where you put your stitches, you run across and you pull it down and put it through one tunnel and you can fix it. And McLaughlin felt like you could fix all of the cuffs with this one running stitch and then put it through one tunnel in the bone. And he showed excellent results with that technique. So we're trying to do that as well. The one thing about convergence is it's not straight across. You have to maintain your obliquity of the tendon muscle pull. So one here may actually go to two anteriorly, not one back over here, and you come further around, and it's okay to use the transverse humeral ligament where the biceps comes through to make sure that you get this done correctly. So it's posterior medial to anterolateral with your usual L-shaped or reverse L-shaped tears. This is how the tendon wants to go back, and it relieves tension, and you can actually do a complete repair. So here we are. On the left is a picture showing you the angle that we're coming in. It's very oblique. It's an accessory posterior medial portal. Here, I like to do retrograde retrievers. This is it coming over the top. We're going to save the biceps and incorporate it into the repair as a graft. We'll cut it in this particular case later on, but this is us coming through that transverse humeral ligament. This is an orthocord suture, so it's semi-absorbable. I have nothing, I make no money off of this, so but I think you need to have a braided suture of some kind, whether it's, because some of the other sutures will actually cut through this tendon. But here we are pulling it together. We have a tiny dog ear, not bad, but now this big tear retracted medial to the glenoid is now sitting right on top of the greater tuberosity. So it's very easy to fix, and it has no tension. With one suture, we took a 5 to 6 centimeter tear in one plane, 5 to 6 in the other, and now basically it's non-displaced. You can add a second and third stitch if you want, same direction, same crossing, use the biceps if you need to as a graft, same kind of stitch. You can use a tape or a ribbon or a braided suture, but again, be very careful about some of the sharper sutures. And then here we are, and it's basically closed, and you could either do one more convergence from this part back here and across, or not. And it's many times we'll do 4 convergence stitches, repass them around the corner, and use a single anchor for a 5 centimeter by 5 centimeter 2.5 tendon tear and fix it with one single anchor. If you don't like doing that, then of course we want medial anchors, and it depends on the size of the tear. So we'll do 1 or 2 triple loaded vented anchors like we talked about, anterior and posterior, or a single one to put in. And then here you have some delamination, and the way we handle that is oblique passing with a retrograde retriever through the delamination at different levels. So we're making sure as we look from lateral that our medial row of stitches is coming through the rotator cuff, medial to the undersurface part of the tear, but lateral to the muscle tendon junction. So we're usually about 5 millimeters lateral to the muscle tendon junction. And we can look top and bottom as we pass this. So we're not bound by an antegrade retriever where we have to just bite at whatever depth it wants. But here we are coming in from an accessory posterior medial portal. You can see the muscle tendon junction. You can see we've preserved the medial bursa, which is kind of still sitting on top. And now we're passing our stitches, so we can do mattress stitches, but with a space between each mattress stitch. As you come closer to the top, we need a different angle. And so we'll show you that in just a second. Here we go. So now we're looking up at our AC joint. It's easier when you do a distal clavicle excision, but you don't have to. And we're going to use the Nevisor portal described by Tommy Nevisor, not Bob. And we'll come in. So we're looking up. Now we'll rotate the scope and look down. So here we are back with our rotator cuff. And now, amazingly enough, we can come right in front of the spine and drop through that rotator cuff and grab one of our sutures. And we can continue our passage. So this is the mate to this one, if you will, is in the upper infraspinatus. And then this one will be in the posterior supraspinatus. So that's that conjoined tendon we were talking about in the anatomical part at the beginning. So this goes together. Now we'll do our anterior cable of the supraspinatus. And so we'll come back, we'll look for our muscle tendon junction, Move it a little bit more laterally, palpate with the tip of this to make sure we're in the cable because we want that cable back. And then come back through the cuff, look at it underneath, and then it's pretty simple to go ahead and grab this stitch, come in through that portal. There's our retriever. It's kind of a straight shot. And once you practice this portal, it really makes the tears easier, even small tears. It's probably the easiest way to pass your stitches through a small tear. The last part of it is to lock in that front part. So Guy has talked about some patients, the supraspinatus will cross over the biceps, or the subscap will cross posterior to the biceps. So we'll come in from the back and pass that last stitch kind of through the biceps to pull it over to the tuberosity a little bit. And then we just retrieve and tie if you want. You can certainly not tie and do a knotless technique by passing 3 and 3 through 2 lateral anchors. I like medial knot tying because I want to make sure I'm not over tensioning. My buddy Hiro Sagaya likes to put his lateral row down and then tie his medial row. I want to know that my medial row has compressed the tendon into my trephination holes in my trough, and that I have not over tensioned it and pulled it too far over. And so the lateral row, you can do 1 or 2 anchors in the lateral footprint. We try to always, as you see here, leave these huge vascular channels, spread the tendon apart. We need blood supply to that area. And so if it's a big tear like this, you may want to use 2 different anchors. I think a knotless technique is pretty good, where you pass all your sutures, but again, preserve those vascular channels. Hawkins and some of our Japanese colleagues had a very nice study that showed a classic speed bridge with crossing sutures totally cuts off the blood supply to the cuff, to the part you're trying to get to heal. And since this is the slowest healing tendon in the body, we really don't want to cut off our blood supply. We want to try to do things that increase the blood supply rather than limit it. 3 quick extras, and we're coming closer to the end now. Suprascapular nerve release, I think, is very important in large tears. We do it on every revision rotator cuff that we do because we want to look at it, number one. I think it's very important. MIHATA and SCR has been a great boon to our rotator cuff population. It's probably doesn't need to be as widely used as it was for a while, but it is an option. And then collagen vascular patch supplementation. I also do a lot of transfers, lower trapezius and latissimus, that's sort of outside the scope of this talk. This talk is on repair of massive cuffs. All right, suprascapular nerve decompression. LaFosse has shown that neuropathy can be a factor in failure. Warner talked about an injection that helps. Here, what you see is we have a retractor sitting in the notch, protecting our nerve and vein and artery so that we can release a little bit more of this. So this is basically an anterior interval slide described by Joe Toro using a retractor through Nevisor's portal to protect the nerve and the arteries. Got to be a little careful here. Our CC ligament's going to be over here to the left, and then we're going to keep retracting and pulling until we can move forward. So here's some more adhesions. We'll clean those up a little bit. Here's the same view. You can see the retractor to the right. I'm very precise with the shaver, but I have no problem if I'm teaching this to one of my fellows. I don't want them to cut the CC ligaments, which you see to the left. You can see the notch, you can see the ligament on top of it. And so we'll switch to a punch and let them work with the punch. Whereas for me, I'm just going to release it with the shaver. And then you move in and you can see the nerve and the artery, and clearly we haven't damaged them. And we'll make sure that that's nice and free and easy to move across. So there's our ligament. See, this one had 2 bands of ligament. We released 1 adhesion. So it's not enough to just do that. We really need to clean this up a little bit. This one was very bound, had a positive nerve study. And then as we come in, now we're going to finish our freeing up. You can see a very thick ligament, and there's the nerve below. We're going to bevel this outer side a little bit, and it's being held right now. Now you have a bifid nerve. You can see there's 2 branches to it. This ligament is in the way clearly. And so we'll have to get rid of that. But there's our nerve, nice and free. And so we've taken that out. So this patient with this bifid nerve with 2 layers of compression on it, a thick ligament, a notch that's kind of sharp, would never heal unless this was released and cleaned up a little bit. So it's very important in these big tears that you at least think about taking a look at it. And we did a paper, it was published, I don't know, 8 or 9 years ago, where we showed a whole factor, 20% increase in strength in these rotator cuffs if we did release the nerve. And these were with grade 4+ atrophy, 50% or more of the muscle gone, and yet they recovered good strength. MIHATA has given us great data. I'm not going to belabor this or go through the technique, but SCR is useful in some patients. I don't use it as much as when it first came out. I didn't find a whole lot better than some of the other things we do. I will tell you that right now, I love using the biceps as an SCR. I leave it attached to the glenoid. I move it on top the tuberosity, sew it down, and then do my repair on top of it. And I think that works just as well, if not better, than a dermal patch, probably better. Not sure about it with the IT band. It depends on how thick it is, but MIHATA keeps thickening up the amount of IT band that he wants to put in. So it's kind of hard to say it's not just a partial tear with a spacer, and maybe the balloon plus a partial repair may be better than, and certainly less time consuming than an SCR. Lastly, the collagen vascular patch. This was something that was developed with Des Bacher for partial tears. He just wanted them to heal more quickly. We used it for massive and revision tears. So the top picture, you see a revision cuff, huge, obviously. There's not much tissue there, some subscap, which we've already fixed. And then we'll converge all of this and put it back together. Then we'll add this patch on top. And I only use the PLLA staples. A lot of people use the peak staples laterally, but I don't feel quite comfortable putting that kind of material in a shoulder that's going to move around. And our results were very good. We looked at 23 patients, large to massive tears, 2/3 of those that had prior surgery, like the picture you see, and then 22 of the 23 healed. One, about 3 or 4 years later, became very arthritic, and we did a shoulder replacement. One partially healed, didn't finish. Our VAS scores were 2 points lower at all time frames, and we MRI'd and we ultrasound them throughout the year, but MRI'd all of these at a year. So we have MRI confirmation that this actually healed and the tendon was quite thick. This was actually a Herodicus award-winning study and was published in AJSM in 2019. Post-op rehab, we go very, very slowly with massive cuffs. The critical time for failure is the first 12 weeks. So for 12 weeks, 90% of those failures, if you look at George Morell's work, occur in those first 12 weeks. And in fact, one of the more critical things of one of the papers he published was that of his patients that at 3 months did not have normal motion, at the end of a year, 100% of those had healed. Of his patients that had normal motion before 12 weeks, 40% failed. 40%. So that tells you how significant this early time is. A lot of cryotherapy, 30 degrees of abduction, neutral rotation gets the best blood flow into the cuff. We only do passive motion pretty much at home for the first 4 to 8 weeks, and we'll do some aquatics. We do start working on posture and scapular rolls early because that opens up the blood supply to the rotator cuff and improves the vascularity. We've started adding in post-op supplements. Juven HMB is a wound healing compound. The people that treat chronic wounds use this quite a bit. And so we've used that. Doxycycline, as Scott Rodeo has shown in some rat studies, is an MMP3 inhibitor. It also kills P. acnes, which is very nice. So we do that for about 2 to 3 weeks. If it's a revision case, we may do it for 6 weeks, depending on the temperature of the shoulder when we're palpating it. We add some vitamin C if the patient can afford it, and try to avoid all anti-inflammatories for the first 4 weeks. What are our complications? Well, first complication is sent into therapy too early. Number one, if you try to force your motion, it repairs the weakest part of the body. I really don't care if they get stiff. We can always do something about that later. So we try to go very, very slowly, pain-free, take our time, nothing that will pull traction on that rotator cuff. Number two, starting pendulums too early. We're all taught that NIR likes pendulum exercises. We should do those early. Those are passive. Those are not passive. There's some very nice and elegant studies that show that when you try to do pendulums, you activate the rotator cuff. And so we delay those for about 3 to 4 weeks until we get some early healing of the tendon to bone. Number three, and therapists love to do this, physiotherapists love active abduction prior to rotator cuff strength recovery. Those are the people you see shrugging their shoulders up. They have a significant problem. And so what happens then is it pulls the repair apart, because the deltoid will function, it'll pull the shoulder up and it'll pull right through your repair. Number four, it's very similar, trying to do erect exercise before the rotator cuff is ready. We try to start supine and then gradually rotate the patient up towards vertical so the rotator cuff has time to remember that it's supposed to work. And then we use ultrasound. We ultrasound every cuff prior to making the next step. It's been very interesting in these pandemic times when patients can't come in, because we've been doing televisits and we're looking at them on the computer, and Most of the time they'll say, look, we'll come in if you can meet us at the clinic and we can do our spacing because I need to ultrasound the shoulder and see what it looks like. It's very, very important to us about that. So what are our results? Well, with our large tears, which were greater than 3 centimeters, 97% of those are healing with these techniques. That's about as good as we're going to get. I would love to get 100%. Good Lord will never let me get 100%. I'm not perfect, but we keep trying to get better. On our massive retracted revision cases, these are the hardest one. They have atrophy, they've had surgery, they have scarring, greater than 5 centimeters, 2.5 tendons, however you want to structure it. We have 94% of these are healing. Prior to the patch, about 88% of these heal. So we've increased 6% of our healing rate. And this is by imaging. This is patients' satisfaction is usually higher, but by imaging, by ultrasound, by MRI scan, we have 94% healing. So in conclusion, and I again appreciate everybody for letting me be a part of this. Your pre-op evaluation is critical. What do you have to work with? What do you need to do? That'll slot you into the repair, the transfer, or the reverse shoulder category, and sometimes just physical therapy. Intraoperatively, have a plan, keep adjusting as you see what's going on, and try to achieve a stable, biomechanically and biologically sound repair. Don't get caught up in the advertising of many anchors is a good idea. Biology is equally as important, if not more so, than biomechanically. And then post-op, let your basic science of healing guide the recovery process. Add and subtract supplements, go slow, use the patient's symptoms. This should not be painful once you get past the early healing phases. So again, it's always great to be with all of you. It's one of my favorite countries, and you are some of my favorite people in the entire world. So it's a great honor to be here, and thank you very much.
Thank you, Bundy. Indeed, an honor for us as well to host you. And it's wonderful listening to all your points. And a couple of these points have raised some questions as well. So if we are ready, can I just start in some more questions? Okay,
Absolutely.
Buddy, the first question comes here. In a stiff shoulder with a cuff tear, would you rehab these patients before they go in for a surgery, or would you straight away take them for surgery?
So I usually try a rehab program first. Some of my patients have waited a bit of time to get in to see me. And so they are ready to go for surgery. Many of them actually will set up their surgery before they ever come in. They'll say, my doctor says I need to have it fixed. We want you to fix it. So they'll pick a date for surgery, and then I'll see them and realize they're stiff. So I don't have a problem doing the releases at the same time. My preference is almost always to try a month or so of therapy for postural correction and to achieve full range of motion. So I want their scapula retracted, and I want their motion back, especially abduction, passive abduction, back to normal. But I wouldn't delay a surgery if it's the appropriate timing to wait for that, but my preference would be to have it done.
Perfect. That answers this question. What about capsular release, Buddy? In every shoulder, would you do a capsular release, or you choose a patient where you do a capsular release with a cuff repair?
So it depends on rotator cuff size. In every patient, I release the coracohumeral ligament, like we showed. I think that's absolutely critical. If there's any loss of motion when the patient goes to sleep, then I'm going to release the capsule wherever that loss of motion is. And the third thing is, if I get in there and the humeral head is sitting on the glenoid and I pull on the arm and it doesn't drop down, I'm going to always release the entire inferior capsule, anterior band, inferior capsule, posterior band. I think that inferior subluxation of the humeral head on the glenoid is very, very critical for rotator cuff healing.
Perfect. Do you manipulate the shoulder when you take them to theater before you're scoping? No,
I do not. I think it creates bleeding and it creates scar. I don't want to do that. I'm very precise about the release. I'm not a manipulation guy. And even after surgery, we looked at this and with Larry Field, my old partner, and about 1 in 300 of our cuff repairs ended up having to have something done. And even on those cases, I don't manipulate first. I will scope, do all of my releases, and then basically check motion and make sure I've released all of the adhesions. But usually I'm not a manipulation guy.
Posterior interval release. Do you still do it? What is the role of a posterior interval release?
Oh, I don't do. Actually, I've never done the posterior rotator interval. So Steve Burkhart does that, and I understand he wants to separate the two. But anatomically, the upper infraspinatus usually blends with the supraspinatus, and he did that as a part of his partial repairs, where he thought the supraspinatus was non-functional, so he would cut between the two and then pull the infraspinatus and subscap up. So Cofield's old slide that he did. And so I don't do posterior releases because I don't think it's anatomic.
Perfect. Do you do a nerve test before operating a massive calf repair to see for a suprascapular neuropathy? Always?
Not always. No, no, no. If I have
So
a good
how do you
indication, so if they have grade 3 or 4 atrophy, there's no point in doing the test because I'm always going to release the nerve.
Okay.
If they have an acute cuff and it seems to be atrophying rapidly, I do a nerve study on those patients. And I'll do that right away because I think that's early atrophy. And the other time I'll do it is an isolated infraspinatus tear. So you see a patient comes in, their supraspinatus is okay, but they have an infraspinatus tear. And Gilles Walsh has described the fact that those infraspinatus tears, sometimes intrasubstance, sometimes partial, sometimes complete, do very, very poorly with surgery. And in that group, I think they have a neuropathy at the spinal glenoid notch. So if I have an isolated infraspinatus tear, they always get a nerve conduction study.
Perfect. What is your take on ripstop stitches? Does it bother the vascularity, the ripstop stitch?
So it depends on what you use for your ripstop stitch. So there's no question that if you cinch it really tightly and close all of that, then you'll have a problem. But most ripstop stitches don't actually compress that much. It's the two that go together and then put down into an anchor that's a problem. Or if you cross from one anchor to the other and then crisscross those, that becomes really, really tight. But a side-to-side ripstop stitch that you bring your sutures around, that suture is never so tight that it cuts off blood supply. That's a great question.
A lot of questions coming up for suprascapular nerve release. Would you do it before the procedure? I mean, before the repair or at the end of the repair? The nerve
I do
release.
it before. Yeah, I do it before the repair because it falls with the coracohumeral release, anterior interval slide. At that point, you're right there.
Okay,
so
perfect.
as you do your anterior interval slide, your CC ligaments are on one side, your supraspinatus is on the other, and you're only about 5 millimeters away at that point from the nerve and the notch. So I just do it right then.
Coracohumeral ligament release. I mean, most of our people don't do it. I mean, they were quite impressed by your technique of a coracohumeral ligament release. Can you just speak on that? How exactly do you do it?
Sure. So I will put the arthroscope will be lateral. And I favor a more anterolateral portal, but it's about 3 centimeters down from the lateral corner of the acromion. So that's our visualization portal. Then with our anterior portal, we'll pull back on the head. We bring the shaver in, and we find the space between the coracoid and the subscapularis, so between the coracoid of the conjoint tendon and the subscapularis. So if you pull back on the head, much like you do with the subscap, then you'll create that subcoracoid space a little bit better, and you can see that. So then once you find that, then you can go medially to the base of the coracoid, and your coracohumeral ligament, both bands will be right there. The critical part is don't push in, because the axillary nerve is only about 15 millimeters inferior to the coracoid at that point. So you got to be very, very cautious about that axillary nerve, especially if you're lateral decubitus. It's a little bit further if you're beach chair, but it's pretty close. And then you run into the plexus. And so you don't want to go distal. So this following the CA ligament down to the coracoid is the easiest roadmap to get to the coracoid. Once you find the bone, you just stay on the bone and work your way medially, and you'll see the ligament and be able to release it.
Perfect.
But my question from my side, here is Dr. Samanta from Calcutta. Do you give some trick on how you release on the subscap tears?
So on the subscap tears, it's very interesting. The more medial they are, so I do two things. One is I will always release the middle glenohumeral ligament. So remember that the axillary nerve is at the bottom of the subscap. And if you do too big a release inferiorly, then you're going to run into the nerve. So I will release the anterior band if I need to, but I'll go very carefully that way, because if the subscap is retracted, the nerve can be exposed. And so I have a video somewhere of actually releasing for subscaps, and then you see the nerve suddenly just pops up. So you have to be very careful. So I'll go down, I'll release the middle glenohumeral ligament first intra-articularly, come down a little bit further, and then try to release the anterior band. But if I run into a gap, I'll just stop at that point. The other thing is that I'll move with a blunt probe, I'll move on the anterior side of the subscapularis and clean off my subcoracoid space. And at that point, the most simple thing is to put a traction stitch in the subscap, pull it up laterally, and then not with a shaver, but kind of bluntly or with a side effect cautery, release on this posterior and its anterior sides. You don't want to stray too far medially, in part because you run into the plexus, but secondly, there's oftentimes two nerves to the subscapularis that insert a little bit laterally. So you can get a subscap insufficiency by doing too aggressive release anterior to the subscap going too medially.
But this is a question regarding biceps. Would you release, cut the biceps distally as well when you do want to include biceps as a as like an SCR?
So it's very interesting. We did a little study. We haven't published it yet. We're still kind of looking at the data, but we started moving the biceps over and sewing it into the cuff and using it as a graft, and then we would cut it and tenodese it distally. Yeah. Makes perfect sense. And so you put the anchor down there. And then one case, I forgot to cut the biceps. Big cuff, took a long time. Finally got it all done, got my patch on. And so I forgot to cut it. That patient did great, no biceps pain. So I went, okay. So then we started alternating where we always release the transverse humeral ligament and clean off the groove. And so half the time we moved the biceps out of the groove and then we would cut it and tenodese it. And half the time we left it alone. It's apparently as soon as you just get it out of the groove, you don't have to cut it. So it's one less thing to do. So now I don't do it at all. We just get the biceps out of the groove and put it with the cuff. And there's 3 different graft things we do with the biceps. So I don't actually tenodese it lower. I just move it. And there's no difference. And I talked to Larry Field, my partner, he did the same kind of informal study and noted no difference as well. So now we just leave it alone.
But how do you evaluate the tension on the biceps? I mean, it could be a bit lax.
If if we're using it as an SCR, so my favorite way to do it is to release the transverse humeral ligament, clean off the groove, lift the biceps up, put it on top of the tuberosity, put an all suture anchor right in the middle of the tuberosity and sew the biceps down right there. So now it's an SCR. For the glenoid side, we're just using the attachment. And on the greater tuberosity side, 1 anchor with 1 or 2 sutures, and then the biceps is there, and then we repair on top of it. The second way that you can do it is you can release it off the glenoid, pull your supraspinatus over, pass the stitch through the cable, and then sew the biceps into the anterior cable of the supraspinatus. That is really elegant because it looks so beautiful. And on ultrasound, it looks like you have this giant thick cable reforming on the supraspinatus. And I'll do that one when I have a supraspinatus muscle, but my tendon is not as good. So a type 2 failure, someone that's had a very atrophied tendon, and I know the tendon's not good. The third thing you can do is you can cut it over there, grab it, put your medial row down, and then pull the biceps over so that it folds at a right angle, and then sew the rest of the cuff over it. Jeff Abrams likes to do that technique. That's probably my least favorite one, just because I want that cuff to heal to bone. I don't want it to heal to the biceps, but I will do that on occasion with bad tendon.
Any techniques, buddy, if you have a very short tendon, the tendon is short. You have a muscle and then the tendon is short. Is there a technique
So there's that is a medialized single row repair with a patch on top for me. So the tendon itself, and this happens more frequently than we would like. Yeah. I think you can safely medialize your footprint about 8 millimeters, maybe 10, into the articular cartilage without causing any loss of motion. So 8 millimeters is usually all I'll do. So it's a shaver. My shavers are 4.5 millimeters, so it's right about 2 shaver widths that I'll medialize. I'll put an anchor there, and then I'll do a mattress simple configuration, trying to stay within the tendon. So a broader mattress stitch, 2 simples going around it, and put it down medially. And then I'll take that Regeneratin patch and put it on top of the muscle and lay it over the rest of the tuberosity. So for the short ones, I medialize it and then cover it.
Okay. So any question from all the other EC members, those who are present? Sundar, Satish, yes, yeah. Rajiv, you have a question. Rajiv, you have to unmute. Rajiv, you have to unmute.
Yeah, Samanta, I want to ask a question.
Yes,
so,
yes.
What is the cutoff of quality of the cuff? I mean, even the fatty infiltration, if it's a grade 3 or 4, even if it's a grade 4, will you go and do a repair?
Yes. So basically, I think Gutierrez should have 6 classes, in my opinion. I think 50%, saying you have 51% atrophy and 49% normal muscle, I'll fix those all day long. And they do really well. I'll decompress the nerve. They get 85, 90% of their strength back. If you had, so up to about 70%, 75% atrophy, if you combine a nerve release and you fix everything else, maybe add the biceps as an SCR, those patients do really, really well. When you get past about 75% atrophy in the supraspinatus, you're not going to get much out of it. And so So we sort of have a rule that we look at it, and if it's, and really try to get medial with our MRI scan, because that's how we grade it. And then if it's 75% of the muscle is gone, then the patient gets the options of reverse shoulder, repair, knowing you won't get your overhead strength back. And we can talk about that. I'll tell you a little trick about that in a minute. Knowing you won't get your overhead strength back. If it's infraspinatus atrophy or subscapularis atrophy, that's grade 5 or 6, a lot of times we start talking to them about muscle transfers. So if you don't have a big HIMATA class of arthritis, and it's a patient that's very active and their main complaint is weakness, not pain, then once you get above 75% atrophy, it's either a muscle transfer or a reverse shoulder. So even the SCRs, if your infraspinatus is totally shot or your subscap is totally shot in terms of grade 5 or 6 atrophy, they're not going to do well with those operations. So you either have to commit to transfers or do an arthroplasty. And if you do a lateral-based arthroplasty, they get external rotation back. If you do a lateral-lateral arthroplasty, then the subscap is completely irrelevant and doesn't have to be fixed. So that's again, that's a whole different subject. But so the atrophy makes a big difference. But I think it would have been nice if Goutalier would have taken it a little bit further. So the French said if there's 50% fatty atrophy, the muscle will never work, but that's proven to be wrong. Burkhart's proven that. I've proven that. There's a lot of people that have said, so if you get up to 75%, then that's different. Then that's probably not going to work. And so those people up to 75% will fix them. Now, there are some that want this huge overhead strength and they have 75% atrophy. They're not going to get it. What I do with those folks is I'll tell them, look, let's let it heal. Let your tendon mature. If you get it all healed and then you're still weak, you're 9 months out from the surgery. Takes the supraspinatus 9 months to mature. We're 9 months out from the surgery. Your ultrasound looks pretty good. Your tendon looks good. You're still weak. At that point, we'll talk to them, if it's a male, about testosterone supplements or anabolic steroids. I use Anavar. Now, this is totally off-label. It's not something that I have enough proof to say, but I can tell you my people that I've done that on who have waited the 9 months have done amazingly well. They've increased their strength. The hard part then is they want to stay on it, and I can't keep them on it. I do 2 cycles to get their strength back. Either works or it doesn't. And if it works, they like, I feel really good. I look better. My wife's happy, all this kind of stuff. But, you know, if it's a female, there's some secondary changes, but we do a lower dose, they get their strength back. The females don't have a problem getting off of it, but the males, they like it. And so I say, okay, you got to talk to your family doctor because you get 2 months from me. That's it. So that's the deal up front. But it does help, but they've got to wait 9 months. That tendon has to be mature before you can do that kind of supplementation.
So, buddy, when you use a collagen vascular patch, how do you stitch it medially? Do you stitch it medially or you just put it and stitch it on the side?
I just put it and staple it. I try to use only 4. Yeah, just for the PLLA staples. I think the staples, as they dissolve, can cause some stiffness. Yep. And so originally we weren't sure it was going to stick, but it's pretty solid when you put it down. So I'll lay it over the top, and a lot of times I'll bring it in from the back as opposed to from the side, because it's really a porous patch. It doesn't make any difference. There's no structure to it. All you're trying to do is stimulate vascularity. And so, and I'll do 4 staples. There are some complications in terms of stiffness. About 1 in 1,000 patients will have a reaction because it is cow, it's a xenograft. And so you have to be really cautious about that, but it's very, very purified. And if they get that edema and you just wait. So we always aspirate, make sure it's not infected. There's not been an infection associated with this yet, according to their registry and according to people that I've talked to, but they can get this big effusion. Actually, I had an orthopedic surgeon from Dallas that I did it on that was doing great. And then all of a sudden he got a big effusion about 8 weeks out. And so we did all the studies and he said, you know, everything was fine. Got a steroid shot. He said, I feel great. I'm going back to rodeoing. So it does happen.
Hi, buddy. Good morning. Satish here.
Yes.
I have few questions. What is your take on partial cuff repair in such massive retracted cuff tears? And second is, what is your take on SCR versus lat dorsal transfers in such massive retracted tears?
Okay, so partial repairs, I think if that's all you can get is a good idea. As long as you can balance subscapularis and infraspinatus, I think that's fine. I think they can always be repaired unless someone has actually cut them out. So if you do the release techniques we talked about, you can always repair the rotator cuff, always. However, there's some times where that you get in there, it's been operated on before, it's too stuck down, or things are just not going well. And in that case, if you repair the subscap and the infrasmedius and bring them up a little bit. So the subscap, Cofield used to do that all the time. He called it a subscap slide, where he would just slide it up a little bit. It had an upper tear. Instead of repairing it to the lesser, would put a suture through the posterior to the bicipital groove and move the subscap up a little bit. Then you move the infraspinatus up a little bit, and you have Burkhart's force couple. You do exactly what Steve talked about, and now you have enough on top to hold down. That's basically the premise of an SCR. SCR is not functional. It holds the head down and lets the rest of the rotator cuff work. It's the same principle as a reverse shoulder. You change your lever arm so that the deltoid can then move the arm around. So for a partial repair, if that's all you can get, especially if you can get them up a little bit, then that's a good idea. The second question is muscle transfer. So we're moving from latissimus transfers for posterior superior cuffs to lower trap transfers. Bassam, Al-Hassan, and Philippe and some of the other guys have just done some amazing work with that lower trap transfer with an Achilles allograft to prolong it up. If you don't have access to an allograft, you can do a hamstring autograft to prolong it and get the same result. Nice thing about an Achilles is you're kind of getting the benefit of an SCR because it's so thick. So a transfer for the posterior superior cuffs work really well. Latissimus transfers, I mean, I am not Christian Gerber. I don't get overhead strength with the latissimus. I get good external rotation strength, but they stay below head height. With the lower trap transfer, I get about 150 of flexion. So that's been pretty good for me. On the subscapularis, if it's all atrophied, I've always done a pec major transfer, split sometimes complete, with good results. However, Bassam has talked about just moving the latissimus up to take the place of that. It has a better angle of force. And so we actually have one coming up as soon as we can resume truly elective surgery, where we're going to do a latissimus instead. And I trust Bassam. If he tells me it's going to work better, it's probably going to work better. So that's a new venture, something fun to do at 65 years old, learn a new operation, and hopefully it'll work better.
Buddy, any experience with in-space balloons?
So we did a couple as a part of the study, and very specific about it. In terms of putting it in the US, we were really limited. We were not allowed to do a repair. We put it in. Both those patients have done very well, better than I expected. Where I think in-space will come in is a partial repair with, you put it back and it'll push the head down. So you do your release and you do your repair as best you can. And then you put the balloon in and it pushes the head down, creates a space and a better fulcrum for the deltoid. And then you get muscle memory and scarring so that then the shoulder functions better. So I think it's going to be a very good addition. I know LaFosse is now using it. He's fixing the cuff and putting a balloon on top. He's actually putting it on top of his latissimus transfers to hold the head down because you get a better fulcrum of action. So it makes tons of sense to me. Just sticking it in a massive cuff where you have lower infraspinatus or subscap, it's not going to work. There's a very nice study out of Germany. Jens Agenkalscher did that one that showed that if you have extended a tear down and around and you don't fix it, the balloon's not going to work. And if you go back to the original study, it was developed for people that had a good anterior and posterior couple where the head was ballooning up through. He pushed it down and the force couple closed, much like a partial repair when you move it up. So biomechanically, if you can achieve that, it makes sense.
Buddy, there's a question.
Sundar is there. Sundar is waiting with a question.
Ask them to please raise the hand. That is easier. Than...
I showed. No, the question is, in a chronic massive cuff test, when the subscap retracts below the glenoid level, in your experience, how often you could bring it and attach it? Because sometimes we find very tough, especially in the chronic massive tests.
So you can, that's probably almost my only indication to do an open repair. And then sometimes I'll add it in. You can usually get it and fix it. The problem is that the further medially it goes. So if it's past the coracoid, you can go find the tendon, you can release it, but as part of that anterior release, you're sitting right by the plexus and you almost always cut the majority of the nerves to the subscap. And so what Steve Burkhardt has said is if you put it back, it'll act as a tenodesis. And if you have enough tendon and it's just sitting there keeping the shoulder back, then maybe it'll function okay. But it's very difficult to go and dissect it off the ribs, which is what you'll have to do, and not cut the nerves. And so you can do posterior to it, you can do anterior to it, but once it retracts medial to the base of the coracoid, then you have a problem. And I don't have a problem trying. I'll grab it and I'll pull it a little bit and I'll put a stitch in it and I'll clean off the underside and the top side. But if it doesn't just slide over at that point, then, I usually rather have made that diagnosis, because most of the time what happens is it's the upper third, 2/3 that will retract and drop down like this, and the bottom is still intact. Now those are different because it's like an L-shaped tear. So when you grab that, you can mobilize that back up. But if the whole thing is off, then that's retracted medial to the base of the coracoid. The chance of putting it back is not terrible, but the chance of it functioning normally is really poor.
Yes, Satish, you wanted to ask?
Yes, sir. In some of these massive cup tear, post repair, they tend to become stiff even after 3 to 4 months. So, do you believe in giving a subacromial shot of steroid in such cases?
Yes. So I don't care if they're stiff. I really would like them to be stiff at 3 months, and then then I'll do a pretty good aggressive physiotherapy between 3 and 4.5 months, and try a lot of aquatic therapy. Try to get them in water somehow so they can really work on moving their arm. But I'll be a little bit more aggressive with my physiotherapy at that point. 4.5 months, I'll do an intraarticular and subacromial cortisone injection. Pre-COVID-19, I would also put them on 5 milligrams of prednisone a day for about a month, and then do the same therapy. And that usually works very well. And you can repeat that. If you do it around 4 months, you can repeat it again at 6 months if they're still stiff. And as I said, only 1 in 300, Larry and I looked at about 10,000 cuffs on this, and only about 1 in 300 actually came to surgery where we had to do a release. And never, ever, though, manipulate a post-repair rotator cuff. Unless they're a year out and your rotator cuff is totally normal to imaging, that's the weakest part of that shoulder. And if you do a manipulation, it's going to come apart. And I see those patients a lot where they had a surgery, they got stiff, they had a manipulation, they have more pain, more weakness, they get an MRI scan, and now you have a massive retracted cuff from the tear from the manipulation. And so you can never say, well, you shouldn't have manipulated, but the patient comes in and now we're dealing with a combination of capsulitis, ankylosis, scarring on the tendon from the manipulation, more atrophy because now they're 6-9 months out and they've not been able to exercise the rotator cuff. So those are very difficult patients. We can get them well, but that's a long process. So they walk in the door and I don't say anything about the doctor. What I do say is you have a very difficult problem. You're going to be a patient for 18 months. You're going to hate me for 4 to 6, and then we'll become friends. So it's a tough one. That's a tough one.
Yes.
That's reassuring anyway.
Yes,
Rupesh, you wanted
is
to
waiting
ask?
for a question.
Yeah, Rajiv.
Yeah, buddy.
Yes.
When you say it's a irreparable cuff, you can't repair it. What is your cutoff?
So unless it's been cut off, unless somebody has resected the tendon, and then you can always fix the tendon back. So I don't think the irreparable cuff actually exists. There are patients, however, who have so much atrophy that repairing the cuff is a waste of time. So I have patients where I've repaired the cuff. I've gone in because they have no function. They're just like this, pseudo-paralytic. And then when we open them up to do a reverse, the tendon looks great. It's covering the head. It's all there. It looks terrific. I'm sure every one of you have had that experience. There's tendon. There's no muscle, but the tendon looks good. So you can repair it. The question is, should you repair it? So the fact that you can get something back doesn't necessarily mean that you should get something back. So our delamination is ahead of time. So if you want to say there's so much atrophy that it's an irreparable cuff, and meaning that even though if you repair the tendon, they're not going to do well, I would agree with you 100%. There are tendons, there are cuffs that we should not even try to fix because they're so bad. We should move right into transfers or replacements. But if you say purely from a technical standpoint, is there a rotator cuff that hasn't had surgery before that you can't fix? The answer to that is no.
Bhupesh, yeah. Bhupesh.
A technical note. You said you will leave the biceps intact in your glenoid and then stitch it in the greater tuberosity. So
Yes.
what is your abduction angle when you're doing that? Because when I listen to that, my worry is if it is in too much of abduction, will adduction be there or will it cause pain?
30 degrees.
30 degrees.
So it's just almost exactly the same as MIHATA's SCR. So it's no different than putting a tensor fascia lata autograft on top. So 30 to 45 degrees of abduction, neutral rotation, and then you have to release the transverse humeral ligament and the bicipital groove because the whole biceps needs to come out. What you don't want to do is have it coming through the transverse humeral ligament and then crossing back over at a right angle to get to the tuberosity. So you have to lift it out of the groove. So I usually will put my anchor in, then I'll grab with a lobster claw type grasper or just a regular grabber, and I'll pull the biceps over and make sure it's lining up straight down the arm, and then I'll pass my stitches and tie it down.
Thank you.
What's your take on CA ligament release and it results in causing anterior superior escape? That's the question which is asked.
So that's actually a very good question. I don't have a problem doing a decompression. When I do my decompression, though, it usually comes from the back. So I elevate the ligament off and I leave it attached to the deltoid. And so way back in the late 80s, when I first started doing this, was a bit of a concern about it. We didn't have a reverse shoulder then. And what I found as I got to do more revision cuffs is that ligament reforms. And so unless you start doing the wrong thing too soon, you don't release the inferior capsule to let the head drop down, you can cause a problem. So then you cut the ligament out, you do a decompression, and you create a path. If your inferior capsule is tight, your cuff's going to fail and it's going right up the top. If you elevate from posterior with your shaver or your cautery or whatever you, or your shaver or your burr, whatever you like to do, and you release it by resecting some bone, then the ligament stays right where it's supposed to be and it scars right back down. So you preserve the arch. And I think arch preservation is important.
Have you ever dynamically seen the depressor effect of the in-space balloon during surgery? I mean, you cannot.
Yes.
Yeah, you do.
It's very impressive. I mean,
Okay,
it's truly amazing.
Oh, perfect, perfect. I think no more questions, and we are end of the time as well. So, are there any more questions from the panel? So, if Samanta, you can just maybe thank Buddy, and then we can just close the meeting. Buddy, thank you.
Yeah, Buddy, this is a great honor that you have accepted our invitation from our society. It's a real honor. I am seeing you that you are doing fine. Take care, because we are all been frightened about this pandemic. I know that what has burned all this, your country has taken over, and we are in the very critical phase in India. So it is a really nice experience. And every time you come here, you meet you, we learn many things from you. So be there.
Very kind.
Buddy, just a last question. Sorry, Samanta. It just somebody typed in. That Ram typed in. He says, "What is the material you're using for SCR? Is it a dermal matrix or an fascia or?"
So if I can't use the biceps, then I currently still use a double dermal patch. Okay. But I'm not a big fan of the dermal patch. Okay. Just so you know.
Perfect, perfect. I think that gives the answer. Samanta, please.
Okay.
Sorry.
All right. Thank you, guys. You guys have a good evening. Good night. Thank you so much.
Thank you very much. It was
great
wonderful.
To see you all.
And thank you very much.
Thank you.
Thank you.
Sandeep.
So this is the new one coming, IPS.
Yeah, you can announce, Samanta.
So this is the no. You are the president. You have to announce, no?
This is a wrist arthroscopy masterclass, all arranged by Samanta, and it's a wonderful masterclass where we have the stalwarts of wrist arthroscopy: Abhijit, Professor Anil Bhatt, Darshan, our friend Vikas Gupta, and Ravi Bhardwaj. Wrist arthroscopy is something which is very, very new in our country. We have very few masters doing it, and people want to understand the indications and techniques of wrist arthroscopy. I think this masterclass should be one thing which should be attended by those who are interested in wrist arthroscopy. Thank you, Samanta, for arranging this wrist arthroscopy. People really wanted this one. Thank you very much.